Today we are going to welcome Hiroo Suami. He's a reconstructive plastic surgeon from Sydney, Australia, and since 2001, he became a world authority on the research in the mapping of the lymphatic system, and he has developed his own method to visualize the lymphatic system in animals, in humans, and he worked with lymphedema therapists. I think we are going to have a very, very interesting discussion today. Welcome, Hiroo.
Yeah, thank you very much for introduction, Dr. Chikly. So it's really a good opportunity for me to share my finding with all of the people.
Great. So maybe I know you started to work with the blue dye. I don't know if you still do that. Then you use peroxide. So what technique are you using recently now for your mapping?
Yeah, so my work is started at the anatomical study, because understanding the normal lymphatic anatomy is just as important to understanding what's happening in the lymphedema. If we don't know about the normal anatomy as a normal control, so we don't understand what's happening in the lymphedema. So initially I started the blue dye, but blue dye can identify the lymphatics, but it's quite messing the tissue, so then cannot find in any more number of the lymphatic channels. And then I switched to using the hydrogen peroxide. That's clear. So can identify more lymphatic vessel in the tissue. But it's still very painstaking dissection process to find the lymphatics. So then I find it like a clinical imaging system is called the indocyanine green fluorescence lymphography. Indocyanine green is a name of the dye. For some reason, so then indocyanine green have a nice characteristic to specifically uptake by the lymphatics. The indocyanine green working in a cadaveric tissue. I injected the indocyanine green to the human cadaver.
Just one question. In the past they used mercury. It was highly toxic. But did he give us a good visualization of the lymphatics? It was a pretty good technique just in terms of anatomy, because it was diffusing pretty well, right?
That's a very good question. So the anatomists originally used the mercury for the 300 years. Since like 18th century, 19th, and the early 20th century, the mercury injection method is like a standard method for the anatomical dissection. The mercury is the excellent material to demonstrate in the lymphatics. However, there is no specificity demonstrated only the lymphatics. Sometimes they injecting the mercury into the human cadaveric tissue. It goes not only the lymphatic, and it also goes to the vein. So the anatomists need to manually selecting the information about the lymphatics by the mercury injection. It seems to be the indocyanine green having some superior aspect for the specificity of the lymphatics.
So you're saying, so they were looking, the veins were more like a tube, and the lymphatic has more of this sausage called a monoliform shape, and that's why they were selecting which one is a vein, which one was a lymphatic with the mercury, just by the shape they were selecting?
Yeah, that's right.
Okay.
And also the branching pattern is different too. The vein is more likely to make in a network structure. However, the lymphatic is running quite independent. Sometimes diverge and they merge together. However, it's mainly running to the straight towards the lymph node. It's quite different when you see the both structure by the naked eyes. So this is my method. My original background is a plastic surgeon. But after developing this method, I switched my career from the surgeon to the anatomical study of the lymphatic system. We don't see the lymphatics in like a cadaveric specimen because lymphatic is collapsed after the death. There is a lymphatic vessel, but we can't see it. Instead, so the blood vessel, including the red blood cells, therefore we can see it. That's the differences. Lymph fluid is clear fluid. After finding the lymphatics, and then I inject in the radio contrast media to show in the lymphatics.
So here we see two hands because you take off the skin, right? You take off the skin.
That's right.
Flat. And how many sites of injection you have for the lymphatics here?
I need like 100 of the injection in the one limb. So then initial dissection takes about more than 2 weeks. Now my technique is improved. Now I can complete the demonstration of one limb within 3 days.
And so you drain with you manually to bring it to the nodes, correct? You inject distally in the extremity and then you drain with your hands to bring the dye up to the nodes?
For this one, I didn't do it. So then I just using the 1 cc syringe to manual pressure of the contrast media.
Okay, that's why it takes 2 weeks, because if you just don't do it, it takes a long time.
Yeah, that's right. Sometimes only contrast media travel the 5 centimeter distance, and then I need to inject it more.
Yeah, okay. So when I did my dissection, I was using our techniques to drain, and within 10 minutes, it was going to the nodes.
Yeah, that's right. So that's my initial experience.
Right.
So now I'm using indocyanine green lymphography for the human cadaver dissection. So this is not the patient. This is the human cadaver. So the first injecting the indocyanine green into the fingers, and then now I holding the indocyanine green camera on my left hand. So this is a view under the fluorescence lymphography system. As I explained it, so the human cadaver tissue had no lymph route into the lymphatic vessel. So that's why they apply the manual lymphatic drainage to facilitating the movement. Injecting the like a finger, so then indocyanine green dye can travel the whole way towards the actual lymph node. This is a way I can see the lymphatic vessel.
Yeah, so you use effleurage, right, to move it. It's some kind of effleurage, continuous pressure with your fingers, right?
Yeah, that's right.
So how deep can you go? Can you see above the fascia, below the fascia, the deeper lymphatics?
This technique is, so then indocyanine green having limitation about the depth. This is the same specimen. I injected the dye into the lymphatic system and then peel off the skin. Indocyanine green can demonstrate in the lymphatic vessel above the deep fascia. So then normally the depth limitation is 1 centimeter depth. So therefore, only the very slender patient, we can see the deep lymphatics occasionally. However, the most likely, we only can see the superficial lymphatic vessel.
We know in the extremities, you have about 70-80% of the flow is superficial.
That's right. We don't have any good method to calculate the amount of the fluid. So this is one of the requirement for the lymphatic research. We don't have a good method to calculate the amount of the lymph flow. So there is many lymphatic vessels existing in the superficial side. However, the number of the deep lymphatic is much small number. It's mainly the deep lymphatic running next to the major artery. So then often only the 2 or 4 lymphatic vessels.
In the whole body, how often do you see anastomosis between the superficial and the deep? Because we say they are quite separated. There are a few places when they connect.
Yeah, that's right. The story is different between a normal situation and the lymphedema condition. In a normal lymphatic anatomy, there is some area for the natural connection between the superficial and the deep, such as the inside of the elbow or inside of the knee. So eventually, both lymphatic system goes to the deep, but in a lymphedema condition, the story is totally different.
Right.
So then any of the changes can happen in lymphedema.
The circulation needs to go deep, eventually go through the thoracic duct or the right lymphatic duct. When one is blocked, it cannot go to the deep. You have a dermal backflow. So now you are much more superficial than you should be, and you will only reach the deep much further where you have a functional group of lymph nodes.
That's exactly. That's same as what I'm understanding, how the body accommodating in a difficult condition. So then I sum up making a very general lymphatic mapping. So it's called as a lymphosomes. So lymphosome is like a skin territory which contains superficial lymphatic vessels connected to the group of the first tier lymph node.
I have 2 questions about that. We have dermatome, we have sclerotome. Why didn't you use lymphotome? Did you make a difference between lymphosome and lymphotome, or it's basically the same idea?
Yeah, it's the same idea.
Yeah. Now, you could do a lymphotome or lymphosome for deeper territory. I mean, you cannot do it with your technique today, but if we have a technique that could visualize the deep lymphatics, we could one day do a superficial and a deep lymphosome or lymphotome map.
Yeah, that's right.
Now, in the face, I can see in blue, you have the pre-auricular, the parotid nodes, submandibular, subchin. You could have sub-territory, one for the submental, one for the submandibular, one for the subangular, one for the parotid, one for the pre-auricular. Sometimes they have temporal nodes. You could separate it in smaller territories, this blue area of the face, correct?
Yeah, that's correct. This is like a general idea,
Okay.
especially for the lay people to understanding what the lymphatics are. So then each of the segment can be divided into the subterritories.
Right.
We are doing a head and neck study as well. So then what you were talking about exactly. So
Right.
I started using this indocyanine lymphography, scanning more than 250 patients at the operation theater.
Now, you did 250 male, female. Did you see a difference between the woman, the man? You know, you have Aborigines, for example, in Australia. You have people different from different countries. Is there a major difference or not too many anatomical variations?
Thank you for asking this question as well. The people are talking about the lymphatic are so much variable between each individual, but I disagree about this idea. So then it's mainly the people are talking about such variability or individual differences. Once we see the lymphatic anatomy, it's quite uniform, especially we consider the relationship between the lymphatic vessel and the lymph node. Every person having a different course, but the main trunk is quite uniform. If we consider like an individual course of the lymphatic vessel, is of course there is individual differences, but we can see like a big picture. There is no big differences.
The general pattern of the territories stay the same, and you don't feel more variability, anatomical variation with veins or with arteries in the lymphatics.
Thank you for this question as well. So there is some anatomical variation. So then, for example, in the arm, so the main lymphatic drainage armpit, but there is some of the optional pathway in the lateral side of the upper. This pathway is already demonstrated by the old anatomists in the 18th centuries. However, this pathway is quite important. Often people having this variation. That's protecting the lymphedema. Presence of this pathway cannot prevent the lymphedema. So I believe having some preventive effect to making the lymphedema get severe.
Right. So we feel the same thing clinically. We call it the cephalic pathway, the Mascagni pathway. It was described by Mascagni, Paolo Mascagni, and the deltopectoral pathways. It's too small to evacuate a big arm. It's a complement. It can help, but it's just too small. You don't have enough volume to evacuate. How many % of people do you feel have cephalic pathways?
I think about like a half of the people, I guess. So the male and the female anatomy are quite similar too. Only difference is its male lymphatic vessel is commonly is larger than female lymphatics. In the lymphedema, there is a specific imaging sign called the dermal backflow. Lymphatic correctly suddenly stop and then start to showing like a spider network type of structure. There is no way to go. And the fluid come up to the skin, just expanding through the lymphatic capillaries. This is a compensation of some anatomical changes.
Which means you can have a dermal backflow without lymphedema because you have an efficient reroute going to an alternate group of nodes. And if it's efficient enough and all the fluid can be rerouted there, you have no clinical lymphedema. That's why we only have 20-30% of lymphedema after surgery. Either compensate by finding other efficient reroute to an unaffected group of nodes. And in that case, the fluid is evacuated and you don't have any clinical edema or lymphedema.
I completely agree about what you're talking about.
When we work on dermal backflow, you have the skin, sometimes you have a discoloration, the sensitivity is different, Sometimes they don't like to sleep on that side. They feel that the extremity is disconnected for the rest of the body. They lost a sense of unity with the body. So there is some difference before you really get the volume change.
This video showing a more extensive case. The lymphatic vessel is diminished now. And then body only using a skin lymphatic. Dermal backflow extended to the shoulder. It's come down to the front chest and then crossing the midline and then switch to the normal lymphatic in the opposite side of the breast region and then carry the fluid towards the contralateral axillary.
Anterior axillo-axillary.
Yeah,
Right.
dermal backflow is composed of the lymphatic capillaries.
Right. So you have lymphatic capillary, but you have a network without borders separating them, a network, and you could go left or you could go right within a 3 centimeter midline.
That's right. That's right. After scanning more than 600 cases for the arms, these are for the breast cancer related lymphedema. Is ipsilateral and the clavicular region is the normal lymphatic pathways. However, there is a 3 additional pathway can be seen in the lymphedema. So we call it the compensatory pathway. These are the parasternal and the contralateral axilla, and then sometimes going back to the parascapular region.
So you have some nodes around the medial border of the scapula.
Yeah, that's right. Conventionally, the lymphedema therapist is try to shifting the fluid towards the growing area. But for the indocyanine green, it doesn't show up these pathways. And then these are the percentage we investigated. 80% of people who underwent the axillary node dissection still drained to the operated axillary area. The clavicular area about 40%, and then parasternal. The contralateral axillary region is not a big percentage, only 5%.
So how many people have 1, 2, 3, or 4? How many pathways do they have in average?
So then some are the 1 pathway, some are having 2 pathway.
1 or 2 is average.
Yeah.
And so you cannot quantify the flow. So we can assume that when you have some nodes going through the axilla, you will find a little flow going there. And as we discussed before the interview, this flow could over time, having fibrotic that develop in the axilla, and little by little, when you check your patient after many sessions, one day you realize there's no more flow in the axilla. I ask you when those percentages have been taken, and you said it's over time. It's an average of all the people you examine, and some have been a year, some have been 6 months, some have been 10 years after the surgery, right? So it's an average of all the cases you had. But I would not bring everybody to the axilla because eventually all the flow, and you probably don't assess it, the flow can be very low in the axilla. So you cannot evacuate a large volume in practice, or eventually over years, it may shut down and the fibrotic tissue being too important to let the flow go through. So I would not just count on it because we see 80%, but we don't quantify how much flow is going through.
Yeah, that's right. So then eventually we need some of the to measure the amount of the flow.
When you start to move the flow, you're going to see that the flow eventually is going to switch. So initial presentation can be what you have, but when you begin to use your hand, put a bit of pressure, stimulate, the lymphangium restart. Sometimes you're going to see a reroute. So after you do a treatment or 2 or 3, my experience is those percentages change. So those initial presentation without treatment, you can have things like this. You begin to treat, you feel under your hand the flow switching and have a preferential direction, and it may change. We have a lot of posterior axillary. We have only 2% here. If we only have one going to the neck, ipsilateral next 37%, usually it's not enough to evacuate a big arm. This is good for initial presentation, but for the clinic, just know that it may change after you work on those lymphatic and change the physiology.
Yeah, so then this is also my anecdotal comment that, so then what we see the big differences is people are treated or untreated by the conservative management. Always the treated patient is faster to move in the lymphatic, the movement of the dye. Here is the leg cases. ipsilateral, inguinal, and the popliteal are the normal lymphatic drainage region. And then these are the additional 6 drainage regions.
If I go upper lateral thigh or gluteal, but let's say upper lateral thigh, the dark black spot, that's not nodes. We don't have nodes there.
That's right. These are the spots. As a plastic surgeon, perforating artery is supplied the blood to the skin. So then when the perforating artery is existing, the perforating lymphatic vessel is connecting between the superficial and the deep. These are the pathway may not be open in a normal condition. However, like a lymphedema condition, body probably using the perforating lymphatic pathway and then try to accessing this from the superficial to the deep.
So this point is not a node. We don't see anything dark red because it's going to the deep from there using the.
That's right. That's right. So then like that is moving towards this black dot spot and then going to be, seems to be disappeared. Seems to be going to the deep. However, this imaging cannot be confirmed. However, these kind of changes we constantly see in a leg lymphedema patient.
And the lower abdominal is not an external iliac node because we have node in the deep there, external iliac, which are different from the inguinal. That's not what we have in what you call the lower abdominal.
Yeah, that's right.
And what do you have in the posterior thigh? It's also a perforating vein, right?
Yeah, posterior thigh also probably going to the deep by the perforating lymphatic vessel.
And gluteal?
Yeah, gluteal. These are also the Mascagni's diagram in the 18th century depicted. There is a lymphatic vessel running to the superior gluteal artery. We often see that like advanced leg lymphedema cases.
Right. Mascagni, 1787. He even showed some of the lymphatic of the dura there. Incredible book.
So these are the percentage similar to the arm lymphatic drainage. Still more than half of the patient seems to be drained towards the growing area.
Yeah, actually, when you think about it, if the lymphatics continue to try to go where they used to go, following the physiology, everything is going to converge towards the inguinal, though they continue to go there, and then there's a blockage, so you have lymphedema. So that's what the therapist is doing. This is an initial presentation. The leg still try to go to the inguinal. There's no way to go through those inguinal. It doesn't go anywhere. You have dermal backflow. 61% is going through the inguinal, but it's blocked there. There's no pathways. So it's going to create a lymphedema. So the lymphatic therapist is going to reroute this flow, 61%, to bring it to a functional group of nodes. Because it continues, because that's where the tube, the lymphatics are converging towards, but they are blocked after a while. So we have to reroute them for alternate pathways. If they didn't go 61% to the inguinal, we would have probably 61% less lymphedema because those are going mostly nowhere. Few of them still can find few nodes going deep, but most of them are blocked there. So you need to reroute that.
Yeah. So definitely the lymphedema service is helping.
Yeah, thank you so much for these images.
Yeah, these mapping we can providing, and then this kind of a navigation of the system for the lymphedema service to providing.
Thank you so much. It's so interesting, Hiroo. Thank you so much, because that's what we do here. We just try to find the most efficient clinical application using this lymphatic anatomy.
Thank you. Bye.